All right. Good morning. Thank you for giving me this opportunity to share, as I call, feedback from the trenches. We are pain management practice located in Cleveland and in Columbus. Um, this is my contact information. We're over the last years getting a lot of referrals for evaluation for high-risk patients, and I thought I'll give you feedback from pain management side and share our research about screening and brief interventions and other points. Please, next slide. Yeah, that's our team in Mayfield Heights. We're a very diverse practice, both staff-wise and patient-wise, very culturally diverse, and growing in both locations. Next slide. I don't need to talk about the severity of opioid crisis. It just pain medicine news last year that all opioid overdose leads to more deaths than motor vehicle accidents. Next slide. I think this slide is extremely important. It's the slide from National Institute of Drug Abuse. And when we usually talk about it, people look at substances. What happens with heroin? What happens with fentanyl? How we can prevent it? How we can deal with it? From pain management point of view, it's all true and accurate. But I want to bring your attention to the relationship between prescribed opioids and non-prescribed opioids, and to look at our policy in Ohio towards that issue. When I came to Ohio, I came from academia about 10 years ago. I worked for a hospital, and then I opened private practice. Definitely prescribed opioids like 15 years ago was a huge problem with ugly pill mills and other problems we had, and they took care of that, which I was very happy that they did. But nevertheless, we see that once they did that and they limited prescribed opioids and non-prescribed opioids, like just heroin, fentanyl, they picked up. And there are even questions if overregulation achieves that, because I hear like from off-the-record conversation with some primary doctors and other doctors that people are so scared to be inspected, to be audited, that sometimes they give people one prescription not to see them again and avoid them complaining. Just look at the next slide. See, it's very disturbing in my opinion, because you see, before we started this process in 2009, this is CDC data. We were like average, right? We were average nationwide. And since then, you see there is a huge gap, with Ohio 2.6 times higher death rate than average in the country. And definitely, social economic factors play a role. I'm fully aware of that, but I don't think they drastically changed over the last 10 years, right? We have the same socio-economic problems more or less we had before, but nevertheless, this gap is going and widen up. So the question is, are there other factors we're missing? Einstein said that if you repeat the same action and you expect a different results, it's a sign of insanity. So, we're repeating the same approach, let's regulate more, let's look more and more at pain doctors, sometimes throw a book at them, but is that achieving the result? And that's another point I want to bring up, and I want to show you some research that can raise some points. Let's go to the next slide. Nobody talks about insurance. I'll just want to mention this letter that was sent to CareSource in March 2018, which raised hard questions about how insurance handles opioid epidemic. I have this letter if anybody wants it. It's public record, very detailed. Let's just go to the next slide. It raised specific concerns, like 5-page letter, and signed by, I think, 15 or something like that, 15 senators. Go to the next page. Let's go to the next slide. And we had similar experience about the same time. We got complaints from patients who blocked access to care. It just, we have like tens of them. Go to the next slide. Sorry for the quality, but more or less the same concern. Services denied, access to care blocked. Go to the next slide. And we did send it to CASOS with free business integrity patient safety concerns. And the response was that they just, denied services. This is one of the AOBs in a massive amount to the extent that I had to terminate them. But the point is not to complain about them, but to show that goodwill declarations and concerns do not necessarily translate into practical changes. And this problem is still not resolved. Next slide. The same population which is at risk for opioid epidemic, and we have high minority population in our practice, is at the same risk. They're at high risk for COVID-19 as well. Just go to the next slide. We actually had several COVID-19 positive cases, and we even done a small research. It's supposed to be published today, but we added some data which is being statistically analyzed, and it will come out hopefully in 2 weeks. We had a lot of exposure to COVID-19 as well. Next. So the main point that I'm going to make is the use of screening brief intervention. There is some kind of disconnect in my experience. When I talk to experts, they're very surprised that somebody needs to be convinced that screening brief intervention is important, that testing to document organic pathology is important. But nevertheless, when you talk to insurance, on many occasions, we have hard time to get it covered, despite strong scientific evidence. Next slide. We were faced with high-risk patients. These are referrals. We're independent practice, so most of the time people send patients to us when things are out of control, then the patient is not getting better, there is a concern, or it's just too difficult. And honestly, their practice, nothing wrong about it, but their practices that want to concentrate on interventional procedures, and they would rather send a difficult patient to us to assess and manage them in other ways. And we combined screening brief intervention assessments with point of care urine drug screening, EMG testing, which is important because chronic pain is oversimplified, can be related to degenerative process, arthritis, which can be seen on imaging, or neurogenic pain on many occasions that can be seen on EMG. We used PEDT form, which I'm going to discuss in a second. We use NARC scores for all patients, and we use ABPM in our guidance in our practice. Next. Yeah, this is pain assessment documentation tool, very simple. It has several components. The first two, analgesia and activities of daily living, can document severity of pain and functional improvement in a very detailed way. Next slide. So we decided to set certain parameters. We said that if pain reduction is 30 to 50%, it's moderate. It's more or less Academy of Pain definition. Above 50% is a significant pain reduction, and more than 70% a very significant pain reduction. Next slide. Functional improvement, if there are two parameters, like, for example, activities of daily living and family life, or sleep, or just other parameters of PEDT, we call it significant. If one parameter, we call it moderate. 3 or more, very significant. Next slide. We enjoy support from American Board of Physical Medicine and Rehabilitation, who helped us to set this program and approved it and reviewed it on February 26th. Next slide. And this is not all data. I don't want to overload you. We have limited time, but there's one of the samples. We have total 155 charts, I think, reviewed. This is just one of the samples. You see that functional improvement, if you look at very significant, you see how it improves with time. which clearly shows that proper monitoring and testing help people to stay in program. And if they stay in the program, which includes physical therapy, include minimally invasive procedure and medical management, they improve functionally. Next slide. And that's the same thing with percentages. You see how very significant improvement at 2 years is significantly higher than in less than 2 years. Next slide. And this is the statistics. It's significantly p less 0.001 and 0.005 between months in program and functional improvement. Next slide. Pain reduction analysis, we more or less see the same picture, significant difference. Next slide. You see also that over time there is an improvement. Next slide. Most patients had at least moderate pain reduction, which is statistically significant at p 0.02, and there is correlation with the time. Next slide. Yeah, and on a personal level, we feel that you need both structured program and you need time with patients. You need to build a rapport. Building a rapport with patients, in our experience, is it makes a huge difference. Next slide. Yeah, and you know, if you build a rapport with a service dog, you definitely build a rapport with the owner. Next slide. Yeah, so, and these are some examples what we're talking about. If we take one component by its own, it has its value. For example, so far validated by studies, recommended by state medical board, and provides a good risk certification. Next slide. However, if the person is smart enough to Google that, you'll just get this. Person never got angry in his life, never had any tensions, and just, you know, completely, you know, never had mood swings. It means basically that's not real. So you can't use any significant, any component by itself. You need a structured program. Next slide. Urine drug screen, heavily relied on the community objective data. However, it requires significant training, and that's what I deal on a daily basis when I get it from primary care providers and other specialties. Next slide. See, this is a common combination. We see fentanyl, oxycodone, and alcohol, and that's pretty straightforward and very concerning. This is a very dangerous situation. Next slide. This is obviously alcohol intake, and it doesn't mean the person is abusing alcohol. It could be alcohol consumption close to testing. Next slide. This is much more challenging because it's the low level of ethyl sulfate. You don't know if it's non-alcoholic drink, if it's alcoholic drink a long time ago. It requires some expertise to figure out what's going on. Next slide. See, this is also classic. I had it. Person is getting Percocet. He's positive for oxycodone. And okay, that's great. The problem is he doesn't have metabolites. And if he doesn't have metabolites, it means that basically the oxycodone was not digested. We've seen it many times. People come with some powder, oxycodone powder under their fingernails even, or bring it to offices and just drop them in urine samples. It's basically a very serious sign of medication misuse and possibly diversion. Next slide. See, this is a normal urine screen, except for one detail. You see in the comment below, in the bottom, it says dilute. So if you don't pay attention to this, you can miss it and prescribe medication to an abuser. Next slide. And this is the saliva testing, which we also implement, and that shows that the person, again, is positive for hydrocodone, benzodiazepine, lorazepam, and marijuana, and he is abusing, misusing recreational substances. Next slide. Well, that's another topic that many people don't bring up. It's high rate of violent threats to pain practitioners. Next slide. That's what we took in our office. Primarily people who are exposed for diverting and misusing medications can be verbally, physically aggressive. Next slide. Broken door hinges, thermos thrown at the staff. And by the way, this was all reported to the police with practically nothing done. Next. Next, harassing messages on cell phone. I don't know how they get it, though most of them do get my cell phone elsewhere. And see, this is repeated phone calls. Again, nothing was done. Next, that type of stuff. Next, yeah. And that's just happened recently. Assault by drug-seeking patient. Next. Yeah, this is a court document. This time they did do something. When it came to physical injury, they did do something. But we still don't have any support, any guard, and any specific, nothing special happened. It's still being deliberated. Next. And that's the letter we wrote, that unprovoked assault of the physician and two female medical assistants deeply concerning. We don't only have an armed guard of police on premises. Most of our staff are women because of the lack of funding secondary to insurance denials of essential services. After screening brief intervention, we do not have appropriate funding for additional security measures. Next. We try to putting it together. We're trying to follow pain management best practices, which was very useful, at least for our practice. We tried to implement it. Next. And that it's a lot of information on this slide, but basically the point we were trying to make is that you need a structured program and you need a combination of different assessment tools. We also implement interview with a live pain psychologist, and that we feel it reduces the cost because the G-code payment by government insurance is less than or even office visit. And when you utilize testing correctly, it actually saves a lot of cost for the system because you identified people and send them to addiction medicine rehabilitation rather than them, misusing recreational drugs and ended up in ICU or maybe, diverting it to other people who end up in the hospitals. And this is our referral base. Next slide. Now we even face higher, we faced additional challenges because there are additional requirements we need to meet during COVID-19 pandemic with less resources. Next. Specifically, they require adjustment to telemedicine screening, withdrawal screening, mental screening, and that's a challenge we deal with. Next slide. We created recorded materials for patients. That's another thing we figured out. Because of different educational levels and attention spans, many times written or typed materials they're not being read, and if they're read, they're not, people don't internalize it well. So we have recorded tutorials. Next slide. In the office and on YouTube, and now we edit videos about the virus and about protection equipment. Next slide. And again, we were very happy that there are declarations are made. We hope they will be translated into action. I think it's important to see that happen. Next. And these are the challenges we face. On one hand, we are required to do things by the state and national guidelines. On the other hand, insurance denies these services. So it's a real catch-22, including actually screening brief intervention. Next slide. Many times decisions and recommendations are made based on financial objectives and not on evidence. And I have specific examples if you want to contact me after the presentation. And there is non-physicians who basically dictating physicians how to practice indirectly, because if insurance decides they're not covering a certain service, in practice, if you have this insurance population and managed care, that would be very challenging for you to perform, or you perform it on your own expense in a limited fashion. Next slide. We also did research on the EMG and NCV with help of Professor Wineapple and Professor June Kimura, who are national experts. Next slide. And we were very happy. I'm not sure you were. In 2017, they came up with a 5-point strategy to combat opioid abuse, misuse, and overdose. Next slide. And one of the points was correctly said as advancement of the practice of pain management to enable access to high quality evidence-based pain care. So on that reduces the burden of pain for individuals, family, and society. And we were very happy it happened. But again, I always ask this question, is anybody aware of anything that changed or happened, or any, grants or any assistance provided on the ground? And I always get silence because we're not aware, and I haven't heard anybody who is aware of what actually was done after this declaration, at least in this area. If you are, let me know. Next slide. Yeah, we got support from Chief Medical Officer, White House Office of National Drug Control Policy. She reviewed some of our data. You may not hear, very nice, you may not hear back from us right away, so hope we will at some point. But again, we feel there is some kind of disconnect between people intention. I think it's maybe in the system there is a disconnect between declarations and what actually happens on the ground. Next slide. So can we change it? And maybe that's one of the reasons I'm talking to you. I think it's an overregulated environment. I was trying to, at some point I wanted to bring a research-oriented partner to the practice, and off the record they told me, why would they go to Ohio to deal with this overregulated environments, constant audits, and they feel book is thrown on pain management physicians, and it's a very difficult patient population when they can go to a different state with less Medicaid population and less regulations. Ohio is one of the 3 most challenging states to practice pain management, at least I think it's 2017, 2018 data. And I think switching from fear to cooperation, spreading knowledge rather than fear, hopefully can change the situation. And those who say I can and those who say I cannot are both right. Thank you.
Thank you, Dr. Margolin. Does anyone have any questions? I know we're a little over our end time for the meeting. Dr. Margolin, I have a question for you. Do you guys, are you and your staff trained in de-escalation techniques for when you speak to the patients?
Yeah, we do.
And we using de-escalation techniques, you'll still have some outbursts like that? Or
well, first of all, it doesn't mean it happens every day.
Right.
Well, we're in practice for 10 years, and these are the worst cases. But in our experience, the worst cases, actually people who are diverting or misusing medication, and they actually threaten to be exposed. And basically, you actually put them out of business by exposing them. Gotcha. And then can be extremely violent, both verbally and sometimes physically. Actually, people with aberrant drug-seeking behavior or addiction or opioid misuse disorder, they actually respond well to de-escalation technique and psychological care.
Are they potentially already in withdrawal?
Patients? We prevent withdrawal. Now, it's a great question. Thank you. It's a big challenge for us because, when I was a fellow, we were trained to gradually expose patients and not to start with opioids and so on, try non-opioid treatments first. But when I came here, most of my referrals are patients who are already on opioids, started by primary care hospitals. And by the way, I didn't mention that. I don't know why, but when they passed the HB 93 law, they made a loophole and exempted the hospitals from supervision, which created an environment. I work for the hospital, and there are great people there, but over the years, I saw that the amount of time they spend and paperwork they use on many occasions is actually much less than private practice. So when I get referral from the hospital, the people are on opioids already. And if we think the prescription is not inappropriate or requires adjustment, we face a big challenge how to do that without causing withdrawal. But we assess withdrawal on every visit, and that's one of our objectives, to prevent withdrawal.
We have a question from the chat that says, great presentation, thank you. Are there many patients open to getting addiction treatment when present and referred?
It's a good question. Well, as an estimate of the last 10 years, we in 2 locations had identified and referred to addiction medicine consultation between 1,800 to 2,000 patients over 10 years. And the regulations say, we consult them, we write them a referral, we provide them addresses, and we offer them assistance to schedule the appointment. But we can't go beyond that. I don't have a police force to send somebody, or even a social worker to send to them to make sure it happens. So I think the results may vary. I think some patients do and some patients don't. And one of the weaknesses of our system that we don't have any middlemen between us and addiction medicine who can help to actually direct patients to addiction medicine. And we're so busy and so understaffed that definitely we cannot do it ourselves.
Okay. Thank you. I don't see any other questions. Anyone else? There was one thing I meant to mention when Dr. Gilson was speaking, is that when we saw the original spike in the middle of May happen with the ODs, we checked our relapse rates, and the relapse rates did not increase for our providers. So they were remaining mostly stable. We did see one agency have an increase in relapse that was related to stimulus checks arriving. But in general, our relapse rates during this pandemic have stayed steady at our providers at least. So I wanted to make sure that was included in that conversation too. So we're wondering again, when time goes on and we look at the overdose fatalities that occurred, were these people in long-term recovery who didn't have tolerance? We know that many of them came out of the prison system and maybe didn't have the support they needed when they came out of the prison system. But we need to look a little broader, because people engaged in treatment actually, at least through our system providers, did not have a significant increase in relapse. So I wanted to share that. Does anyone else have announcements before we close out the meeting?
Tom Gilson, I just had a question. I got a unsolicited email over the weekend about supporting some legislative thing. It was about the Department of Agriculture banning kratom, and it was to sign a letter to oppose that. Did anybody else get that? They addressed me as another opioid task force member. I sit on this one in the U.S. Attorney's Task Force and then other groups, but I didn't know where that came from, and it was kind of something I disagreed with anyway, but I just thought it was an inappropriate use of contact information too.
Yeah, I didn't receive anything like that. I wonder where they got your contact information from.
I have not had a chance to check my email. I am just returning to the office today, so I will check, Dr. Gilson, and see if I have that.
Fair enough. I assumed it wasn't vetted through anybody.
Yeah.
But okay.
That's interesting.
It is.
Thank you so much. I'll go back to the procedure room.
Thanks, Dr.
Thank you,
Margolin.
Doctor.
Any questions, please email me. Thank you.
Okay.
Any other announcements? I guess I have one. So since we've been doing all this COVID stuff for our OD2A grant, one thing that we've really had to transition with is our peer-to-peer recovery coaches that we have in the EDs. And I wanted to say that I would give a shout out to Woodrow, Aaron Helms. They did a great job with quickly transitioning into telehealth, and they've still had great success. So I think that's a win, at least, so that we didn't see people kind of getting lost in the COVID situation. So thank you, Erin, for all the hard work you did behind that.
On that same note, across the system, we saw that no-show rates decreased, which means more people were keeping their IOP appointments with telehealth. So that was a big game changer. We saw at least system-wide that happened with that shift in telehealth. So is some advocacy work happening on the state level to make sure that telehealth stays in play. So we'll see where that goes.
That's good to hear.
Yeah.
Karen, have you guys had some virtual presentations for improbable players, or you kind of tabling that? I don't know if you're still on. No, I think she's gone.
All right. Anyone else? It was good to see a lot of faces. We'll send out the recording and the minutes and copies of the presentations too for everybody in the next day or so. All right.
Thank you. Our next meeting is what, August 18th? I think.
I'm relying on your memory because I don't have it in front of me.
I know it was on the agenda somewhere.
Fantastic.
We'll send it out.
We'll
Thanks,
send
you
out
guys. Good meeting.
Thanks, guys. Bye.
Thanks, everybody.